All right, I'm going to just have us jump in because I know we'll have so much to talk about. Thank you everyone for joining. We're really fortunate, and I'm especially thrilled to have Eeshani Kandpal from CGD. CGD is your primary affiliation, right, Eeshani? Formerly of the World Bank, now of CGD, but just a really terrific scholar, and I always enjoy reading her work. And she's going to talk to us about health worker, the impact of performance-based financing on health worker motivation. And Eeshani is going to talk, and we'll leave time at the end for sort of questions, comments. So I'll let you take it away whenever you're ready.
Thank you. Thanks, Maggie. We were just speaking of imposter syndrome, so nice way to kick that in for me with those kind words. Always fantastic to hear those sorts of things about oneself from someone that you admire yourself so much. So great to be back. I think I last presented in this seminar, maybe it's been a couple of years perhaps. But really value your feedback on this work, which is which we're sort of approaching the wrap-up stage at this point. And so, you know, I have a couple of specific questions for you, but really would welcome any and all ideas as we aim to finish up a full draft pretty soon. So the paper I'm going to present today is looking at the effect of performance-based financing on health worker motivation and satisfaction, using experiments that were run independently but part of a larger World Bank portfolio of impact evaluations in 6 low and middle income countries.
Sorry to interrupt you, Eeshani. Are you meant to be projecting your slides? Because I'm not seeing them right now.
Oh, yes, I thought I was. Let me just. Thanks for the heads up here. Okay, are you seeing them now?
Now we see them. Yes.
Perfect. Thank you. And you're seeing the presenter view, right?
Yes.
The presentation view.
Yeah.
Yeah. Perfect. Okay. So this is work with Sneha Lamba, who's a recent PhD in public health from Hopkins. Jed Friedman, who's a lead economist at the. We've been working together for so long. We've all been promoted over time. Sneha actually just finished her PhD and is a postdoc at the University of Göttingen. Jed Friedman is a lead economist in the World Bank's research department. And as Maggie mentioned, I recently moved to the Center for Global Development as a senior fellow and currently on leave from the World Bank's research department, where I'm a senior economist as well. So all of the evidence I'm going to present today builds on this large impact evaluation portfolio at the World Bank, which studied the implementation and various aspects of the process of implementation of performance-based financing interventions in low and middle income countries. Now, why do we care about this, the effects of PBF, performance-based financing, on health worker motivation and satisfaction? So these interventions, you know, just to make sure we're on the same page, they're an umbrella intervention, and they one of their important or primary criteria are that they offer financial incentives to clinics or to health workers, and the amount of the incentive is calculated based on the quantity and quality of services. These are very common. At sort of the peak of this wave of PBF interventions, 32 out of 46 sub-Saharan African countries had at least one pilot ongoing, and this is in about 2017. Some of these didn't get scaled up, others did. So the number is a little bit lower now, but we're still talking about maybe about half of those countries still having a performance-based financing scheme in place at this point in time. The goal of PBF schemes is to increase the efficiency of health spending. So that is to say that, you know, to improve the quantity or the quality of service delivery while holding constant the spending level. So it's not necessarily representing, or it's generally not representing an increase in the amount of spending, just how it's dispersed. There may be additional channels of impact, though, that are distinct from the additional financing, or the change in financing, if you will. So the first is that PBF interventions provide the front lines with an operating budget over which they have control. And in many sub-Saharan African settings, this is a big departure from business as usual in itself, because these frontline facilities typically don't have an operating budget of their own. They get like the payroll is sort of delivered in the hospital's bank account or the clinic's bank account on a regular schedule. Similarly, they get drugs and supplies based on the size of the facility and the package of services the facility is supposed to deliver, again at sort of routine intervals. If something breaks, then they have to go through the centralized procurement channels. So instead, what PBF does is it sort of gives them autonomy over a budget, and then the idea there, as proposed by Bruno Mason and co-authors, is that autonomy then translates into autonomy over clinical decision making as well, and in turn can reduce absenteeism and improve health worker motivation. Now, there are longstanding concerns, though, that PBF could actually be counterproductive in terms of health worker motivation and satisfaction. This is tied to some work that suggests that maybe financial incentives crowd out intrinsic motivation. There's also some PBF-specific critiques that have gained some traction, including, or maybe especially this op-ed by Elizabeth Paul and co-authors, where they argue that what PBF does is it's ignoring the complexity of the health system. And so in the short run, you're tying extrinsic motivation, right, these financial incentives, to worker actions. And in doing that, when the pilot ends, when the PBF incentives run out, you end up demotivating the workforce because you replace that intrinsic motivation with extrinsic motivation. And then when the source of extrinsic motivation runs out, then you're sort of worse off in the long run. Much of the behavioral evidence, though, at least, is not exactly, we think, applicable to the PBF setting. And that's because it investigates the introduction of incentives to unincentivized tasks, right? So the Nisi and Rusticchini paper is about daycare, right? And when there's like a late fee or there's like a fee for late pickups, then parents actually pay the fee and then show up late on a regular basis. That's an unintended consequence. Then there's like a lot of work tied to blood donation, but these are tasks or actions that are never really tied to incentives, sort of as a concept, right? And you're introducing incentives to them. In contrast, in these PBF interventions, I mean, these are for pay public sector workers. They're being paid to do their job. This is just changing the way in which at least part of their salary is dispersed. So instead of giving all of their salaries a flat salary, they're giving them part of it tied to the quantity and quality of services delivered. So there's been some work that looks at the impact of PBF on health worker motivation, by and large, a single context, and or often not using experimental evidence. But a scholar who's done some really nice work in this field is Julia Lohman. So what we're going to try and do here is think a little bit about the theory and what that would tell us, to then tie that back to experimental evidence on the effect of PBF on health worker motivation and satisfaction from these RCT pilots. So in terms of theory, I just want to sort of briefly touch upon a couple of theories that are relevant here. So the first is cognitive evaluation theory, which is quite old. It goes back to the 1960s. And it basically suggests a model of extrinsic and intrinsic work motivation, where financial rewards, competition, and evaluations, if anything, undermine intrinsic motivation. So they're very much sort of pitched against each other. But then there is also self-determination theory, which sort of expands on cognitive evaluation theory and says, well, motivation is actually existing along a continuum, and it has key domains, relatedness, which is not as relevant here, but autonomy and competence are the other two important domains of self-determination theory. And it says, effectively, just as as human beings, we have sort of food intake needs. Similarly, we have core needs for these three domains of self-determination. And so, and we derive motivation from things like competence and autonomy. So, we can certainly think of models where self-determination theory or hypotheses where self-determination theory would suggest that there are many different types of extrinsic and intrinsic motivation, and I'll talk a little bit about what we can measure in our data shortly. But basically, the introduction of SDT into the world of CET would suggest that there's a bit of an ambiguity in which way the results should go, at least in theory, the effect of PBF on motivation and satisfaction, and motivation in particular. So, the change in the incentive form can reduce motivation if it is somehow seen as controlling, right? So if you're like taking away someone's autonomy by tying their specific actions to payments, right? That could be viewed as the individual as sort of micromanaging. On the other hand, if it's seen as sort of an increased signal of a signal of increased confidence, or even just a relevance of the work that they're doing, right? By saying that this action of yours we think is really important, so we're going to measure it and pay you for it. That might actually, if anything, be increasing motivation. Okay, so in terms of the specific research question, like I said, we're going to be studying these 6 impact evaluations, or you're using data from these 6 impact evaluations to study the effects of PBF on health worker motivation and satisfaction in Cameroon, Nigeria, Zambia, and Zimbabwe, as well as Kyrgyzstan and Tajikistan. And so the overall question, of course, is, did PBF intervention in these settings affect motivation and satisfaction? And specifically, is there any evidence to support this Hall et al. Critique of intrinsic motivation crowding out? Or, through that ambiguous link with theory, is it the other channel that wins out? Which is that health worker satisfaction or motivation actually increase. And we're going to be presenting today the comparison of PBF to pure controls. And I will come back at the very end to note that we do have in the data in some of these pilots a counterfactual, which is just decentralized facility financing in equivalent amount. And so we're working on expanding. That's like the last piece of analysis we're wrapping up right now, is comparing that, the decentralized facility financing, which isn't tied to performance pay, but holds constant the budget envelope to PBF, and just gives the front lines autonomy. Compare that to PBF and compare that to pure controls as well. So let me just check to see if there are any questions at this point. Okay. Move on to data and setting. So here are the 6 countries and the 6 specific PBF interventions. Do you see my cursor moving?
Yes.
Okay.
Yes, we do.
Great. So in these 6 settings, 4 of them were district level randomization. So LGAs in Nigeria are comparable to districts. In Kyrgyzstan and Cameroon, it was slightly different. In Kyrgyzstan, we did, these were district level hospitals that were randomized into one of 3 treatment arms, and this was triplet matched. And in Cameroon, there was facility level randomization. All of these interventions have impact evaluations that have been published, and we're using the data from those impact evaluations here. So all of them have a PBF arm. Typically, the PBF arm also includes additional supervision. Sometimes there's a little bit more structure, as in Cameroon and Kyrgyzstan, in the supervision. But even in the other 4, by design, when the district health teams go to collect the data or to conduct an audit, there's a de facto supervision visit that also happens. And so sort of by design, all of the PBF interventions include some enhanced supervision as well. And they all have a pure control arm, which is what we're going to be looking at today. So the health worker data comes from facility level surveys that were carried out for these impact evaluations at baseline, and then a midline or an end line in all of these countries. The follow-up was generally about 2 years after the baseline, except for Nigeria, where it was closer to 2.5, sometimes inching on 3 years after baseline. Okay, so when we say motivation and satisfaction, what do the constructs actually mean, and how are they different from each other? So motivation includes self-concept, autonomy, recognition, the work environment is feeding into your motivation. And I'll show you like specific statements to make this a little bit more concrete that we asked in the survey, the health workers, but just sort of go through them now. Leadership, so how motivated you feel by the facility's leadership, teamwork, and changes is sort of a measure of flexibility. For satisfaction, the key subconstructs are satisfaction with your relationships at work, with work conditions, with respect and recognition, with career opportunities, and with compensation and benefits. And you know, in terms of the theory, I really focused on motivation because that's where the theoretical or the sort of the Paul et al. Critique also comes in, is specifically talking about motivation. But I do want to note that PBF directly affects or potentially affects satisfaction by improving compensation and benefits, right? It can also be in the form of reducing delays. So, you know, one important subcomponent of the umbrella intervention that is a PBF intervention is to sort of unclog the public expenditure systems. And so, for example, in Nigeria at baseline, 66% of health workers told us that they hadn't received their salary in its entirety for the last 3 months, and 75% told us that there were, you know, delays of several weeks each month in receiving their salary. One benefit of PBF is that because there's like an investment and an improvement upstream in the public expenditure tracking system, those delays go down quite a bit. Further, there's obviously like the respect and recognition angle. You know, you're getting these visits from the district health team who might otherwise never interact with the frontline facility in these sorts of settings. And the work conditions also, you know, all of these interventions, these are health financing reforms, right? They do bring in additional funds for facility level improvements that are not tied to like the incentive-based payment, but there can be an improvement in infrastructure, et cetera, which can certainly improve your job satisfaction. I also want to note that these subconstructs differ by country, but they do have overlap. So what I'm presenting here are the main subconstructs that we've conceptualized that we see across the countries. And of course, you know, these are all subjective evaluations, whether they are of your own motivation or of conditions related to your job. And then the constructs around motivation are designed specifically to measure beliefs that determine behavior, whereas the satisfaction constructs, as you can see, sort of measure the degree of satisfaction with your job. So of course they can be highly correlated, but they are designed to be measuring different things. And that's a point I wanted to make. So for example, you could be highly motivated, but also highly dissatisfied, right? There's definitely a point in my career where I felt like I was very motivated and very dissatisfied with some aspects of my job. So with that said, let's move on to the data. So the dependent variables we're going to use are going to be aggregate scores of motivation and satisfaction, and then also motivation and satisfaction as measured by these subconstructs. These were measured using your standard Likert scales. The instruments were adapted for each country, and respondents were asked things like, you know, to what extent would you agree with a sentence like this? So staff willingly share their expertise with other members, and the responses could be most of the time, more than half the time, less than half the time, only rarely, or never. And then to what extent are you satisfied with different aspects of your life in a health facility, such as, you know, working relationships with other facility staff, or, you know, your interactions with your supervisor. And they could respond with things like extremely dissatisfied, dissatisfied, indifferent, satisfied, or extremely satisfied. So how we're going to aggregate and decide, what the subconstructs are, et cetera, is by using first exploratory factor analysis for each of these 6 countries separately. And we're going to generate these measures of motivation and satisfaction that are informed by item response theory. So exploratory factor analysis has been used quite extensively to measure health worker behavior in low and middle income countries, because there's really no sort of cross-cutting framework or even like a very strong theory on the dimensionality of motivation. And this is work, really nice work by Joe Borghi and co-authors. So that's why we rely on exploratory factor analysis, and also we do it separately for each country, recognizing the heterogeneity across the settings. Then we use parallel analysis to decide on the dimensionality, which is the number of factors to retain. Again, this is something we do country by country. And so here, basically what happens is you generate like a random, you have a randomly generated data set with the same number of observations and variables as your main data. And then you only retain the factors that have eigenvalues that are greater for the actual data than for the randomly generated data. The threshold we use for dropping factors is 0.4 in terms of eigenvalues. And then just as a robustness, in addition to these exploratory factor analysis based aggregates, we also use PCA based factor scores and just naive scale scores, right? Just aggregating those Likert scales. And the results are consistent, but based on the Borghi et al. Paper, we think the exploratory factor analysis results are the most robust, and that's what I'm going to be showing you. So what are we measuring? In terms of the job satisfaction scale, the domains that we construct, the subconstructs, are compensation and benefits. So this is a specific example for Zimbabwe, sorry. Compensation, benefits, management, opportunities, relationships, respect and recognition, safety and security, and working conditions. And there are statements pertaining to salary, to other benefits, to opportunities for promotion, living accommodations, if there's schooling available for your children, things like that. Overall quality of management of the health facility, and then any opportunities that are available to upgrade skills, to discuss work issues, higher up, things like that. And then under working conditions, again, things that might be very directly affected by facility level autonomy, right? So if, for example, a facility has a stock out under PBF, it can actually use some of its operating budget to end that stock out. Whereas previously it would have to, request through centralized procurement additional drugs and consumables, which can extend the stock out considerably. So working conditions, I think is very, very clearly potentially affected by these sorts of interventions. But you could also certainly, imagine that through the supervision trainings, they might be viewed as like additional opportunities to upgrade your skills, so on and so forth. For the motivation scale, this is an example from Tajikistan. The constructs are autonomy, changes or flexibility, recognition, self-concept, teamwork and work environment. And so, it's sort of agreement with statements like, my job allows me freedom in how I organize my work, and the approaches and methods that I can use in doing my job. I'm given enough authority by my supervisors to do my job well. So clearly, if you have more decentralization and more autonomy as a result of a PDF pilot, this can be affected. I think, I'll just leave this here for like 5 seconds, just for you to have a look. But, there are also statements about overall quality of teamwork, like staff take steps to prevent problems arising between them. And this we think is important to measure and to retain because, for example, of work by Ken Leonard and co-authors, who show that sometimes health workers perform when they're working in teams, they perform at a level that's actually higher than what they assessed at in an individual vignette. And that seems to be coming from that sort of like the effect of the interaction within the team. You might have complementary skills, or working in a team somehow jogs your memory, you remember something. And so to the extent that PBF might be improving general motivation and morale, we might see effects on teamwork as well. Okay. So the exploratory factor analysis results are in the form of these Cronbach's alphas, which are reported here for those different domains. And again, in bold are the ones that we sort of see as being large and meaningful across settings. Similarly, this is for satisfaction. Now, moving on to what we actually do with these, right? So we've constructed using the exploratory factor analysis and looking at those Cronbach alphas, we've constructed these aggregates for motivation and satisfaction. Now we're going to be running a difference in differences estimation with facility fixed effects for each country. I just want to say that we don't have a negative weights problem here, because in all of these interventions, the treatment turns on at the same time, and then we're sort of either at the end of the treatment period for everyone, or the intervention is still ongoing, which it was only in Kyrgyzstan at that point, and only for like an additional month after the N-line survey. So that entire hot mess that is the DID literature, fortunately, we can avoid those challenges there. Okay, so just like a pretty straightforward DID specification then, and then this is obviously the gamma 3 is the coefficient of interest, which is picking up the impact of being in a PBF facility after the treatment started. We're going to be controlling for health worker level controls like the sex of the health worker, the cadre, the years of experience. I'm going to be showing you results with and without the X, and this barely changes. It doesn't really change the gamma 3 estimates. Obviously, we're working on interacting the X's with the PBF W as well for like a more correct specification. Okay, so we're going to be looking at results that are using these EFA derived, not driven, EFA, sorry about that typo, EFA derived scale scores as a dependent variable, and also looking at selected subconstructs that are common to multiple countries. We're going to be including these individual level controls. Okay. So just in terms of descriptive stats, I don't have a whole lot to say. These are again on those Likert scales. I do want to note that there are clearly national level differences in motivation, and as you'll see on the next slide, also in satisfaction. But to the extent that these levels are fixed at the national level over time, those levels differences don't affect our impact estimates, but still, it's something to keep in mind when we're interpreting results across countries that there are these levels differences. These are for satisfaction, and these are again all at baseline. Okay, so moving into results. So first of all, here are just the overall motivation, satisfaction, and then we also have the WHO well-being scale that we look at, just to make sure that we're not missing anything by only focusing on motivation and satisfaction. And the key takeaway here, each point estimate represents a country, and then these are 99 and 90, sort of 99 and 95% confidence intervals there. The first takeaway is that there are really no effects on motivation. So if the concern is that PBF is leading to these tremendous demotivating effects, I mean, we're not seeing this in these 6 countries using RCTs, right? We're also not seeing effects in general anywhere, with the exception of a couple of countries for for satisfaction. If anything, maybe there is like some with some noise, there's like maybe a positive effect on satisfaction. Again, not surprising given that so much of satisfaction is tied to working conditions and other things that might be affected directly by the PBF interventions. And again, no significant effects, very small significant effects, very small coefficient estimates, and no significant effects on that overall WHO well-being scale. So now looking at some of the sub-constructs, so motivation from self-concept does seem to increase significantly as a result of PBF in Nigeria and in Zimbabwe. I'll come to Zimbabwe in a second. In Nigeria, I do want to say that this PBF intervention, the autonomy aspect of it really was a dramatic departure. This was one of the more centralized settings that was part of this group of PBF pilots. And so the PBF pilot represented, relative to the baseline, a larger increase in autonomy in Nigeria than it did in some of the other places. And so in Nigeria, in addition to the operating budget, there was also like an important component pertaining the ability to procure drugs and supplies locally from drugstores, as opposed to going through the Nigerian centralized procurement system, which is notoriously slow and inefficient. And so these sorts of changes, even though they might be affecting satisfaction, they might also have knock-on effects on motivation, for example, because you're receiving a signal of your trustworthiness implicitly, right? Because you're just being allowed to do more independently. There was also the ability to hire contract staff in Nigeria, for instance, which, when there's like, for example, when malaria is endemic, and there's like a lot of demand for facility services, the ability to have some contract workers can really lighten the workload of health workers, which might again have some effects on motivation. I think I see some questions in the chat. Anything I should address, or I see something in the chat?
I think it's an AI bot
Okay.
so far, so I don't see any questions at this point. Yeah.
Sounds good. Okay. And then, so yes, in Zimbabwe, the interesting thing is motivation increases from all the subconstructs that we look at. And so, and significantly so. And so the thing to note about the Zimbabwe pilot is that it came after a really moribund period in the country more broadly, but definitely for the health system. And so it is entirely possible that at baseline health staff were particularly demotivated, even relative to other countries. And so that's why we're picking up some of these larger effects here. And in Nigeria, the last thing I do want to go back to is that, and we'll see this a bit more clearly in terms of the satisfaction results. But again, there were these very, very large delays in payments, salary payments, and getting rid of those was a large part of the improvements that came from the PBF program. So in terms of satisfaction, here we do see a broader set of impacts. In Nigeria for some subconstructs, in Cameroon, in Tajikistan, and Zambia, and then in Zimbabwe, interestingly enough, we don't see as many impacts on satisfaction as we did on motivation. The only setting where we don't really see a lot of improvement in terms of satisfaction from working conditions is Kyrgyzstan. And having spent a lot of time on this pilot, I do want to note that these were district level hospitals, as I mentioned early on. These were of these facilities, of these, the 6 sets of facilities, by far the best sort of provisioned. They're maternity hospitals or maternity wards in hospitals, tertiary hospitals, as opposed to the frontline clinics in Kyrgyzstan. So that's less surprising. In terms of satisfaction from rewards and benefits, this is where Nigeria really pops up, and this isn't a change in the level. This is really more about in the disbursement, the lack of delays in disbursement. We're seeing that here. Not a whole lot of change in terms of satisfaction from facility level relationships, which is not entirely surprising given also some of our um, the qualitative data. So 5 of these countries, all but Cameroon, had a large qualitative study as well. And in all of those, it does seem that the PBF pilots didn't really affect interactions within existing staff at the facility level. Which was a little surprising to us because you would expect with the additional autonomy there would be some effects at least on interactions within staff, but we don't pick that up. Although the in many instances the impacts are positive, they're just not anywhere near significant. Okay, so to wrap up, overall we don't find any evidence of like a systematic relationship between the introduction of performance-based financing and either worker satisfaction or motivation across these 6 countries. In Nigeria and Zimbabwe, it is true that we find overall motivation, and specifically motivation from self-concept, right, which is really intrinsic motivation, going up in PBF facilities compared to control facilities. And so, there is some evidence not of the Paul et al. Critique that PBF demotivated staff, but in fact, if anything, that there might be positive effects on staff's intrinsic motivation. And so, we think that that critique is something that we can sort of set aside for PBF. Now, if you've read some of my other work on health financing, you'll have seen, for instance, that there are not a lot of impacts of PBF on health outcomes. And so there may be other reasons for which to question PBF, but this demotivational effect on health workers doesn't seem to be one. And we think this is, the most robust body of evidence on this question so far. And again, on worker satisfaction, there is fairly broad-based evidence from these 6 settings that satisfaction from work conditions increased in PBF facilities, and overall satisfaction was also higher. Again, not surprising because there is additional financing and the working conditions are improving in all of these facilities. So, no evidence of demotivational effects. Hopefully this sets that Paul et al. Critique to rest. Whether we should be doing PBF is an entirely different question that I have lots of thoughts on. I'm happy to talk about. In terms of next steps, I think we think it's important to look at that counterfactual of enhanced financing, which we have for a subset of the countries in our study. So that's Nigeria, Zambia, Zimbabwe, and Cameroon is where we would have that. And then enhanced supervision we have in Kyrgyzstan and Cameroon. So we can do that comparison as well. One question that I had that I would love feedback on is whether both of these are interesting or one of them is more interesting than the other. Also like for public health papers, obviously, complexity is not necessarily desirable. And so we're wondering to what extent to bring all these results into one paper versus, keep the focus on the PBF versus pure controls. And then the other thing is when we do the interaction of the treatment effect with the covariates, the individual level covariates, to what extent do we want to talk about the results there? So those of you who are familiar, for example, with the Donato, Miller, Mohanan, AJ applied on the characteristics of workers and how they interact with responsiveness to PBF, that's the sort of story that we could tell with an interaction of individual level characteristics and PBF. But again, we don't really know if that would be like out of place in a public health paper like this, whether that should be something that we delve into separately, or if that's not interesting, it's fairly obvious and known at this point. So those were 2 questions I wanted to ask specifically for feedback on. And one limitation that I want to end with, which is the first one, I think is fairly obvious that the scales and subconstructs do vary to some level by country. But, one critique of PBF that ties into this demotivating effect is potentially that they only kick in, sometime after the intervention ends, right? And we are relatively close to the end of each intervention. And as I said, in one instance, the intervention was still ongoing for another month or so. So if the demotivating effects don't kick in until much later, then we would miss them. That said, at least in theory, we don't see ex ante why that would be true, right? What would be the reason for the demotivating effects only to kick in after some delay? If anything, they should be the most acute, like right when your incentives end that you've been so used to. But I wanted to mention that, and if there are any thoughts on that, I'd be very happy to have those as well.
Great. Thank you so much, Eeshani. Yeah, you might want to switch your camera because I saw you earlier fine, but now I only see the top of your head.
Oh, sorry about that.
When we were chatting earlier, I saw you. No worries.
Yeah.
So I see there's one comment in the chat from JSI about motivation, and is motivation satisfaction, do you think it's coming from personal gain or improvement in service quality?
Just trying to figure out why my computer is being really glitchy right now. Just give me 1 second. You are not seeing my screen anymore, is it?
No, I just see you.
Okay. All right. I don't see you. There we go. Okay. Right, much better. So the question is the motivation and satisfaction due to personal gain or improvement in service quality? So the way that the constructs are created, the idea would be that it would be motivation that would improve from like the quality of work you're doing, not so much satisfaction. So it certainly could be that, and it would be very much a part of the way that we conceive of motivation for it to increase as a result of an improvement in service quality. For satisfaction, I think it would have to be more tied to something like working conditions or your, the satisfaction with your salary, things like that. I don't know if that answers the question.
I think that's helpful. I mean, I think this is really interesting. I like the idea of sort of laying it out theoretically and conceptually. I can give you offline thoughts on journal strategies, which you can take with a grain of salt because who knows. But I think, you mentioned the sort of payment delays and the idea that sort of, health workers, who are kind of underpaid and sometimes never paid, are sort of doing this out of the goodness of their hearts. It's sort of only an idea you'd find in like the health sphere, right? There's not in other spheres, we don't sort of expect people to kind of basically work for nothing, I think this sort of, so it's an interesting argument. And I really like the idea of taking it head on. Having looked at some of this data, one thing that has often struck me is like how satisfied people say they are, given that that they're not being paid and their working conditions are really challenging, that the overall like rates of reporting and being satisfied are pretty high. So I wonder if you can kind of reflect on that. And I know that one thing that, Margaret Crack and some of my other colleagues have tried to kind of tackle is, how do you figure out what it means to be satisfied in a place where you've come to expect, relatively poor treatment, right? If you expect your payments to be late and not on time and to not have like real supervision or feedback, what does it kind of mean to be, satisfied in that kind of setting? Yeah, so that was my one thought, and then I see we have other comments in the chat.
Yeah, so let me expand a bit on what you said, because I have exact same reaction to that critique, which is that why should we expect people Like, it doesn't matter, you know, you are a professor, you are supposed to be intrinsically motivated as well, and you are, but that doesn't mean that you shouldn't be paid for your work. You know, we don't expect this necessarily of the workforce in the education sector even. But, you know, especially, for example, like the community health worker cadre, the expectation around the world is that they will work without pay or without recognition, without training, without acknowledgement. And I really thanks, Maggie, for letting me rant about this a bit, because it drives me nuts. I find it extremely paternalistic and condescending, honestly. So that's sort of just to agree with you there. On the levels of satisfaction, I do agree that the levels are, you know, given how poor the infrastructure is and how significant the payment delays are. The levels themselves can be surprising. I don't have a good answer to your question of, you know, what does it mean to be satisfied in this setting. I think we can look into the qualitative reports a bit more. We do see, to some extent, in, you know, sort of just the time that I have spent in health facilities in Kyrgyzstan and Nigeria, I have seen an element of surprise, right, when conditions have improved. And again, Kyrgyzstan, just to note again, is definitely at the sort of an outlier in terms of how well provisioned those facilities are, you know, by virtue of being a higher level, but also this being a former Soviet state. So we could definitely think a little bit more about what it means to be, you know, satisfied, and for there to be an improvement in satisfaction based on things that we would all sort of take for granted here, right? I see a couple more questions. So the last one is, in terms of questionable donor funding, how do you see the sustainability? Yeah, so I mean, this is exactly what we're talking about, right? Is the critique of PBF is that it is, not only is it, you know, not sustainable because aid flows are volatile, but it's also it degrades the health system by crowding out intrinsic motivation and replacing it with extrinsic motivation. And we don't see any evidence for that. So if the question is, you know, are PBF pilots sustainable? The answer to that is, you know, I think it really depends on the context. And by and large, I would say that many of even the more successful pilots haven't been scaled up over time. Suggesting that there may be real concerns of sustainability there. But in terms of the impacts on motivation and satisfaction, generating an avenue of concern in terms of sustainability, like, I think that is the critique that we can lay to rest here. And then there's a longer question here that I'm going to take a second to read. Okay, so this is a question about DRGs or other performance-linked disbursement mechanisms for NCDs. So I know that there is a study by Damien DeWalk, Adana Chukuma, and others looking at I think on the demand side, incentives, financial incentives for screening for NCDs. Off the top of my head, I can't think of a study that looks at performance-based financing on the supply side, like an impact evaluation. I know that there have been experiences, but I'm blanking out on the supply side, i.e., if one comes to mind, I'll be sure to mention it.
I had one other question, Eeshani. You know, I've been thinking about this in terms of like payment delays, and, you know, for me, there's like a bunch of missing steps here. I think for health audiences, that sort of, you know, one question is like, how much does it matter if health workers are motivated and satisfied? And it seems sort of very likely to me that it matters a lot, but the evidence is challenging, right? So like, I wondered if I don't know if you're able to look at sort of downstream or how this relates to like, attrition or turnover, not showing up for work, the kinds of things that we think of ultimately really mattering if you have a sort of kind of fed up health workforce. Like, you worry that they will leave, you worry that there'll be turnover, you worry that it'll be hard to get people to come to work. So I wonder about those kind of variables in your analysis and how they're related to some of these motivation satisfaction measures.
Yeah, so I think that's a great question. And there's where I thought you were going, which I think we can do definitely is like an additional paper, or like even a blog post. Honestly, at this point, I don't have the bandwidth to take on a new paper, but maybe we should talk about doing this paper together. But at some point in the future. But that would be the link between motivation and satisfaction and outcomes, right? For the worker or at the facility level. And we could certainly do this in Kyrgyzstan, where we actually have pretty good admin data on ICD-10 codes, on diagnostic codes. On attrition and turnover, this is something that we've talked to Dan Honig about, but it would require basically manually coding across waves health workers by name. And so that just becomes, it's a really important question. And certainly I think, from other domains of public sector employment, we see that link that you're referring to. But in health, and certainly with our data, it would be quite a heavy lift, just in terms of getting the data set up. Which is not to say it's not, and many of these studies are in the public domain, and so just because we can't do it doesn't mean that someone should definitely do it.
Yeah, I have a doctoral student who's really interested in this sort of, question. So maybe him and I will follow up, because, getting get data on what happens longitudinally with health workers is pretty hard, but it seems like a kind of piece of the puzzle that fits into the rest of them that would be interesting to explore. I don't want to monopolize, so I know there are a bunch of other people on. If you want to unmute or raise your hand, we'd love to hear from you if there are any other questions.
I want to ask just one follow-up question. So it seems a lot of the evidence you presented is already coming from so many different countries, so it's kind of generalizable per se. But I want to ask you, whether there is any specific things that work in the different settings you look at, or something that didn't work, some specific challenges. I've been working at the health facility level in different countries, and each sector is specific, and maybe the level of intrinsic motivation or financial payment, so on, is so different across settings. So I was just wondering, like, thinking even more in terms of how generalizable these results would be in other settings, like whether you can speak to anything that really worked well or didn't work well, or some of the differences or common things across the settings you look at.
So if you will permit me the indulgence of, like, not necessarily using the evidence from this paper that I showed you, but the fact that I have worked in health financing now for a long time, and so to use my own stock of knowledge there, I think there are a few components that are really important. I think if it's a centralized health system, I think direct facility financing, and I do apologize for having said decentralized earlier, because that's a bigger term, and we just mean a relatively modest, literally just giving the facilities some flexible financing to the frontline facilities. I think that's a really powerful and impactful reform in and of itself. No questions asked there. I think we don't have a lot of experience with this as much as we would like, but another thing that can make a big impact is having a combination of demand and supply side interventions. In a very small number of instances, we have studies that combine both, and where they do, we see sort of there's like an interaction effect, I guess is what I'm trying to say. Another thing is this ability to hire contract workers. And these can be more like community health worker type cadres. They don't need a lot of training, but if there is, like, for example, a malaria outbreak, and you have the ability to procure RDTs, right? Then if you even have members of the community who can help with the testing and starting ART, for instance, that can be very impactful. And then the last thing is, so the last time I presented in this seminar, I think about a couple of years back, Maggie, if memory serves, is a paper with Sebastian Bauhoff, who is one of your colleagues, where we look at the effect of performance pay on like in a lab in the field setup, but then we were also able to measure effects on performance after the experiment ended. And this is a component that we have added more recently in response to some referee comments. And this is real world patient provider interactions that we observed. And we see that, you know, the lab in the field experiment that we did, we incentivized certain components, and then actions that were tied to that, there's a higher level of performance on those in these real world, real effort, you know, high stakes, not super high stakes, it's ANC, but, you know, actual stakes in, interactions. And that suggests that what performance pay is actually doing behaviorally is amplifying the signal of salience that is being sent by the measurement and like the purchasing. So there's really no effect of like an increase in the price that you're paying and the incentive that you're paying. There's a discontinuous jump in performance from like no incentive to like some positive incentive, but then diminishing marginal returns kick in like very, very quickly. So if what performance pay is doing is amplifying that signal of salience, you know, this is an important task and that's why I'm paying you for it. I think first of all, that has implications for training interventions, right? So when you're training, you know, if there's something that's really important, tie like a small reward to it of some sort. And then the second is, it also tells us a lot, I think, about spillovers, right? Is how you can price in effort on unincentivized services, basically by purchasing some subset of complementary tasks. So, you know, understanding that price is primarily, the performance incentive is primarily amplifying the signal of salience, I think it's something that's underappreciated in the literature. And like, for example, at the World Bank, people in operations will spend a lot of time thinking about what the right price is. And then how do you, you know, price like another service, and how should you be increasing the price over time? Should be decreasing it? It turns out maybe you don't have to do any of that. So those would be, you know,
Thank you.
again, not from this evidence, but like from my
That's very
version
helpful.
in this literature.
Thank you.
Yeah, I think that's an excellent insight about price, you know, as a sort of signal that you see on these like supply side, and you see it on the demand side as well. So
Exactly.
I think we should go. I have some follow-ups that I'll send you by email, Eeshani, but I want to thank you so much. This is a terrific talk. Love hearing about what you're working on, and we appreciate you joining us. Thanks everyone for being here.
Thank you. Thanks for the invitation.
See you soon.
Thanks for the comments.
Bye.
Bye.